Hello everyone. Today I'm going to be talking about the facial nerve. The facial nerve has two parts, the main motor part and a smaller nervus intermedius. The nervus intermedius has two components, a sensory component with fibers from the ear surface, external surface of the tympanic membrane, and taste from the anterior two-thirds of the tongue via the chorda tympani, which all pass to the geniculus ganglion. Then another component is parasympathetic fibers from the superior salivatory nucleus to the submandibular, sublingual, and lacrimal glands. These fibers course within the greater superficial petrosal nerve. Now, as I mentioned when I was talking about the sixth nerve, the two landmarks that help us to find where the nucleus of the sixth as well as seventh nerve sit, and these are the little bumps on the floor of the fourth ventricle, the facial colliculi. Now, the facial colliculi are formed because of the seventh nerve fibers which pass around the sixth nerve nucleus. If we look at this diagram, we can see that only the motor fibers of the seventh nerve pass around the nucleus of the sixth nerve. The parasympathetic and the sensory fibers exit directly. But however, it's the fibers, the motor fibers that go around the sixth that form the facial colliculus. So the two nuclei are quite close together, the sixth and the seventh. What is the pathology in this case? Correct. As Gino said, infarct. As we can see, restricted diffusion, ADC, and then T2 and flare. And again, this patient had facial palsy and ptosis due to an infarct. And again, both nerves were involved because of the proximity of the two structures. Again, notice the enlarged facial colliculus on this side. Another condition, what do we see here? Nate also mentioned infarct, and Nate now mentioned MS, correct? Here we have a lesion involving the colliculus. This patient had MS and also had facial nerve symptoms, again because of the position of the nucleus. Sometimes because of the proximity of the nuclei, you'll have patients with both nerves involved. Like this patient has an enlarged colliculus, abnormal signal. Patient was MS with both the sixth and nerve palsies. Here's another patient from the literature, again MS, showing both sixth and seventh nerve palsies, again because of the proximity here. What is the condition here of a patient who had seventh nerve symptoms? Anybody? What's causing this dark signal? Correct. As Nate said, siderosis due to a cavernoma. This was a cavernoma, again, with seventh nerve symptoms. In this case I showed before, when I was talking about the sixth nerve, this patient had sixth and seventh nerve palsy, an HIV patient with immunoblastic lymphoma. This horseshoe involvement, again, would involve the region of the nuclei. Patient with lower face palsy, possible condition here. We used to see a lot of these, not as much nowadays. Daniel mentioned TB, not bad. Correct. Eric mentioned the correct diagnosis, toxo. This was a patient with toxo and had lower face palsy. Again, a lesion in the region of the nuclei. Why sometimes only the 7th is involved or only the 6th is unclear, but many times both of them are involved. This was a patient with breast carcinoma, had a lid droop, and again, we see a lesion in the region of the nucleus, 7th nerve nucleus. This was an extremely unusual case sent to me by a former fellow. Metastatic disease, but what was the condition here? Patient had facial paralysis. Something that we don't think of as having mets to the brain. Correct. Nate made the right diagnosis. This was a patient with metastatic prostate cancer and happened to have lesion in the brain, and including the one that caused the facial paralysis. This case I showed before, patient had 6th and 7th nerve palsy, had negative DWI, negative flare. The only thing we saw was this enhancement, and we felt that this likely was some sort of a small vascular lesion. It has this kind of linear appearance here, but again presented both with 6th and 7th nerve palsies. Sometimes we'll see the 7th nerve on a DWI study. You can see, as I showed before, here's the 6th, but at the same time the 7th also was visible. And again, if we look at this T2, we can see the 6th, and here's the 7th nerve, and posterior to it is the 8th. And of course, every time I have to show hemosiderosis, this was post-op for a GBM, and again, the 5th nerve, the 6th nerve, the 3rd nerve, and of course, here's the 7th nerve and the 8th nerve, all covered with hemosiderin because of the extensive bleeding. Now, when I was talking about the trigeminal nerve, I talked about patients with trigeminal neuralgia due to the vascular conflict. We can see here the right trigeminal nerve deformed by an artery. And this has also been described as neurovascular conflict. And remember, I stress how important it is to have thin T2s both in the coronal and the axial plane to show, for instance, in this case, here's the trigeminal nerve with the artery crossing and deforming the nerve on the coronal plane, and we can see this conflict in the crossing in the axial plane. Well, there's another condition where this neurovascular conflict is a possible cause, and that's hemifacial spasm. And we can see in this patient with hemifacial spasm, this was actually the vert pressing on the root entry zone of the 7th nerve. And again, on this thin T2, we again to see the nerve, and here the vessel, and we can see also the relationship in the coronal plane. So in this condition, again, it's important to have the appropriate studies to identify this neurovascular conflict. Here's another patient, had left hemifacial spasm secondary to the pica, which we can see here, and here's the nerve, and we can see the conflict, or at least the impression by the artery at the root entry zone of the seventh nerve, on this axial tilted image. Here's a nice coronal thin T2 showing, again, this nicely. Here's the artery coming there up, the pica, and here we can see the seventh nerve, and we can see how the artery impinges on the root entry zone, likely the cause of this patient left hemifacial spasm. This patient failed Botox treatment. And here's again to show, sometimes you don't see the entire arteries or the entire nerve, but here you could see outlined. So here's the pica coming off the vertebral artery, and here's the seventh nerve, and this is the eighth nerve, and here's the artery. And we can see how the seventh nerve is approaching the artery. And here on an adjacent slide, we can see how the arteries and the nerve are going to be meeting here. And if you look at the whole case on the monitor, it's easier to see this motion. So this was right hemifacial spasm because of conflict or impingement of the artery, the pica, on the seventh nerve. Here's some other case, left hemifacial spasm. Here's the pica artery coming up. And again, we see here's the artery, a little bit of the nerve on the coronal. We see the artery here and the nerve, and the same here. Here's the seventh nerve. The eighth nerve is behind, and here's the pica. And here I did a reformat sagittal, and you can see the artery impinging at the root, at the pontomedullary junction, where the seventh nerve comes out on the sagittal plane. Now, one of the issues is this loop of the ICA. Many times we'll see the ICA, anterior inferior cerebellar artery, looping into the opening of the internal auditory canal, sometimes even quite deeply. Most of the time the patients are asymptomatic, but in this case, the patient had a left facial palsy. And the question was, is this caused by the artery, or is this just an incidental finding? It's really hard to say, but at least you can see that there's some deformity of the nerves here. So possibly this was the cause, although it's not for sure. Here's another situation. This patient had left facial nerve fasciculations. And again, we see an arterial branch here, which we usually don't see all the way almost to the fundus of the IAC. And again, here we see the nerves. And is this already causing some problem which caused the fasciculation? It's not clear, but at least it's suspicious, because usually we don't see such a large vessel within the canal. Okay, let's talk a little bit the anatomy of the internal auditory canal. First of all, in this diagram of the nerves going into the internal auditory canal, we have 4 nerves. Today I'm only going to be talking about the facial, next time about the rest. So anterior superior, or 7 up, is the facial nerve. Below it is the 8th, the cochlear. Posterior we have the 2 vestibular divisions. Now the 7th nerve, and here if we look at this, look into the fundus, anterior here, posterior here. So this is the opening for the 7th. This is the opening for the cochlear branches, and this superior vestibular and inferior vestibular. Now, the components of the facial nerve. So this is the facial nerve in the canal. This is the labyrinthine portion, which leads to the genicular ganglion. Here we see a portion of the tympanic part of the nerve, and this is an important branch, the superior nerve, which I'll talk about later, the greater superficial petrosal nerve. And if we look at this diagram that shows the entire facial nerve, so we have here the genicular ganglion, the labyrinthine portion in the IAC, then we have the tympanic segment, then we have the genu here, and this is the mastoid segment leading down into the parotid. And we can see that on axial CT. So here's the IAC. This is the important labyrinthine segment. This is where the genicular ganglion would be sitting. Here's the tympanic segment. And on this reformatted coronal, we see an entire course, the tympanic and the mastoid segment, just like in this diagram. On MR, we usually don't see as much, but we'll see that. So here's the seventh nerve entering the internal auditory canal with the eighth behind it. And here's the area where the genicular ganglion would be sitting. Now we can also identify the components of the facial nerve on this. Here's the sagittal view. We can see the genu here, so a little bit of the tympanic, and look at the entire course of the mastoid segment. And also on coronal, we can identify the mastoid segment. Here's a nice, another sagittal the Ash gave me. On the flare image, we see the mastoid segment and also the main trunk within the region of the parotid gland. Now, let me just mention a little bit of neurology here. The cortical bulbar fibers from one frontal lobe synapse with both the ipsilateral and contralateral forehead neurons, and only the contralateral lower facial nerve syndrome. So we have two conditions. Sometimes the neurologist will mention it to you. There's central facial paralysis or supranuclear injury that affects the contralateral muscle but spares the forehead. So it would be like this patient here who has a palsy, you can see, of the lower face, but the forehead is okay. Then you have a peripheral lesion, which is injury to the nerve from the level of the brainstem to the motor end. All the ipsilateral muscles are affected. So you can see on this patient, he cannot elevate the forehead, or the forehead is involved in the entire face. So supranuclear and a peripheral injury. Now, some interesting issues about the facial canal. The facial canal has various, that is, the nerve occupies various portions of the diameter of the facial canal. Notice in the labyrinthine segment, 63% of the diameter of the canal is involved by the nerve, less in the tympanic and least by the mastoid. So that makes the labyrinthine segment the most vulnerable because of this tight space. It's also least vascularized and most likely the site of entrapment. We can see in this diagram and this histologic picture, here's the nerve within the facial canal. There's a rich vascular complex around it. However, in the labyrinthine portion, this would be quite small, and it makes the nerve susceptible, the labyrinthine segment, to injury, inflammation, or trauma. Just the supply of the facial canal anteriorly, it's the middle meningeal. In the middle, it's ascending pharyngeal, and then also a branch from the occipital, the stylomastoid. Now, one other thing I wanted to show here is sometimes the clinicians will come to you with the facial nerve symptoms which are not the full nerve, but just segments relating to wherever the injury is. So if we look at this diagram here, so here's the motor division, and then there are the paracentric and the sensory. And you can see the division here, 1 through 5, and their injury, if the injury is involving, let's say, the tympanic segment, this portion further back, or the mastoid, you'll get different symptoms. So if it's high up, let's say in the region of the IAC, you'll have peripheral motor paralysis and also an impairment of hearing, deafness, and vestibular excitability. And then depending where the injury is, you'll have less and less. So let's say at level 2, you may have motor paralysis and impairment of taste and lacrimation and salivary. But as you go down, you may end up, let's say, in the mastoid segment only with motor symptoms. And for instance, you may have involvement of the sapedius higher up. So sometimes the clinicians will mention that to you. So just be aware, depending where the injury is, you may have all the functions involved, only partial involvement. What's wrong with this patient? Correct. Both Matt and Gino mentioned longitudinal fracture. And this patient had 7th nerve palsy, and you can see normally here's the tympanic segment, here's a part, it's where the geniculum would be sitting, the labyrinthine, and here we have the fracture, at least involving the tympanic portion. This was an interesting case that Ajay and Ajay may have given it to me, but it was a very interesting. This was a young patient that at a very early age was diagnosed with left facial palsy. And what do we see here? Correct. As Nate said, there's enlargement of the labyrinthine portion, the tympanic portion, and the mastoid segment. Look, compared to this side, where it's normal. And on MR, we can see the same findings. Look at the size here of the tympanic portion. Look at the massive size of the mastoid segment, both on the coronal and on the sagittal plane. And the likely diagnosis here, or Dan also mentioned enlarged canal. Correct, as everybody, Dan, Nate mentioned, and possibly the condition here. Correct, as Nate said, and Anshu, NF, correct. Likely NF. Now, sometimes you'll have this condition. For instance, we can see here in the tympanic and the mastoid segment. What is this? Also, the resident mentioned TZ, mentioned NF2. Very nice. What are we seeing here? This was actually an older patient. Yeah, it looks a little large, I agree, the mastoid segment. But what is the line that I'm pointing to with the arrow? What's the linear calcification? That's actually a split of the canal. Now, it's much more common in young people with all kind of inner ear abnormalities to have a duplicated facial canal. This is a whole topic by itself, and I'm not going to go into it, but I just want to show that incidentally, you may see this kind of splitting of the facial canal, and this usually is a congenital anomaly that where you see many abnormalities, anomalies of the inner ear. Okay, why am I showing this case and what's wrong here? Correct. Gino pointed out this was a cholesteatoma, as we can see, and the patient presented with facial nerve palsy. And as Gino said, there's erosion of this segment of the facial canal. So what is this segment? Here's a normal. We should see two areas here of the facial canal. And this one, this is a normal, and in this patient, it's eroded by the cholesteatoma. And this is two. So what are these two things that we're seeing both on MR and on coronal CT? If we look at this anatomic diagram here, I put this red line here. So this is the labyrinthine segment leading toward the genicular ganglion, and then we have the beginning of the tympanic. So what we have here, so this is the distal labyrinthine segment, and this is the proximal tympanic segment. So because in the coronal, we're cutting both of them. So again, distal labyrinthine, proximal tympanic, seen both on MR and on CT. So it was the proximal tympanic segment which was eroded in this patient, causing the facial palsy. This is just showing enhancement in the genicular ganglia. Here's a patient with Bell's palsy, which we frequently see when we read MRs. And this is like the classic where you have enhancement in the fundus of the canal, enhancement of the geniculum, but this is the telltale. The labyrinthine portion is very important to identify. Once you identify enhancement in the labyrinthine portion, you know that the seventh nerve is involved. There's no other structure goes through the labyrinthine portion. It's very small and thin, but it's easy to see most of the time when it abnormally enhances. Here was a patient had a Bell's palsy with herpes zoster. Again, we see enhancement within the IAC. Here's a patient, right facial symptoms, was question of herpetic Bell's palsy. And again, IAC is involved, but definitely here's the labyrinthine portion, genicular is involved. Again, the two so-called snake eyes, the distal labyrinthine, proximal tympanic, involvement here of the upper portion of the internal auditory canal, and nicely we can see on the sagittal plane the mastoid segment, and we can even see some of the branching of the facial nerve within the gland here, the parotid. And if you compare the two sides, see a little more structures on this side. These may be some of the facial nerve branches within the parotid. And here again is the mastoid segment. Patient with bilateral facial nerve palsies. Again, notice the labyrinthine portion. Possible condition. Okay, Nate mentioned the number, but he mentioned the correct, and Gino mentioned the correct. Very unusual to have both nerves involved. And we see that the other nerves involved here, the trigeminal both on the coronal and on the axial. And of course, I always show a case of that. That's Lyme, okay? I mean, otherwise it's unusual to see both, unless it's lymphoma, some other metastatic disease. But this is Lyme involving several nerves, but both seventh, and that's why he had the palsy, bilateral palsy. Here's another patient, first developed the sixth and then Bell's palsy, and we see the multiple nerves involved, the third, a little bit of the sixth here, but of course here's the seventh and the fifth again, so not unusual to see multiple nerves with Lyme. This was an interesting case. A young patient presented with Guillain-Barré syndrome, acute polyneuropathy, had enhancement of the conus here. And notice, look at all the enhancement and thickening of the nerves in the lumbar region. And the diagnosis, they then did a brain MR. And what do we see? Again, both facial nerves are involved. Again, labyrinthine segment, area of the genicular ganglion, also the fifth, and our disease again, Lyme. So this Lyme, patient with Lyme presented with spinal, with polyneuropathy, although there were many other nerves involved here. As Gino said, Miller-Fisher variant. Very good, Gino. And then I won't ask for differential because it's always the same. Here's a patient with lymphoma, involvement of the IAC, labyrinthine portion, always the landmark, labyrinthine portion, and geniculate. If you look here in the IAC, you really can't tell which nerves are involved. But once you see the labyrinthine segment, you know it's involving the seventh. And here we also see some involvement of the third and the fifth nerves. Another case of lymphoma, and here we see here we see the IAC, upper part of the IAC. Again, here's a labyrinthine segment. So we know the seventh is involved, and here on the sagittal view, the mastoid segment leading towards the parietal gland. Leukemia, again, multiple nerves, the fifth, the third, both IACs. What's involved? We again know the seventh because we see the labyrinthine portion very minimally small. You remember, it's very small, but it is enhancing, so we know the seventh is involved. Also the geniculate ganglion region. Now here's a patient leukemia, multiple involvement, Meckel's cave, fifth nerve, a lesion in the pons. But of course, here's the IAC. Here we see the labyrinthine portion, a little bit of the tympanic, genicular ganglion, and this is a little bit of the greater superficial petrosal nerve that I'll talk about later. Patient's metastatic breast disease, lesion in the brain, a little bit of third, fifth. Both IACs are involved, but we note that the seventh is again here because of the labyrinthine portion. Another case of breast metastatic disease, severe involvement, sulci in the cerebellum, multiple nerve, the fifth. Here we may not see the labyrinthine, but we see the area of the genicular ganglion, again IAC. Now here's a very interesting case. Patient presented with the seventh nerve symptoms. What do we see? We see enhancement along the base, the temporal fossa. We see enhancement of the third division of the trigeminal nerve, again involvement of the skull base. Here on the sagittal view, we see the mandibular division enhancing, and here's the foramen ovalis I showed last time in the axial plane. So there's a lot of enhancement here. But why does the patient have seventh nerve symptoms? We can see that, again, there's enhancement in the upper internal auditory canal. Again, a little bit here, the genicular ganglion is enhancing. And again, here's the enhancement in the skull base near this vessel, which is the middle meningeal artery. When I saw this, I became very excited. What is this vessel here? This is the artery I mentioned before. This is the greater superficial petrosal nerve, and I'll go into detail on this. So we see that here. If we again look at this, so here's the genicular ganglion. This is the greater superficial petrosal nerve. I'll go into this in detail. But the question was, what is causing all this enhancement? What is the abnormality here? Any possible diagnoses? Correct. As mentioned, metastatic disease. Anshu and Nate mentioned the correct possible diagnosis. And what other study did I suggest should be done? Correct. As Dan said, CT. And CT gave the diagnosis. And what do we see on CT? We see the classic hyperostosis of the greater wing of the sphenoid on this side that we see with meningioma. And as Nate and Dan, and people mentioned, so this was a meningioma case. Back to the issue, why did this patient have hearing or facial nerve symptoms? So let's talk about the greater superficial petrosal nerve. So here again, in this anatomic diagram, this is the ganglia, the genicular ganglion. This is the greater superficial petrosal nerve. We can see it here, and this enhanced, this is the ganglion. We see a little bit of the nerve here. The greater superficial petrosal nerve carries parasympathetic fibers from the superior salivatory nucleus to the submandibular, sublingual, and lacrimal glands. Netter shows beautifully this relationship. What happens to this nerve? So here again, this is the greater superficial petrosal nerve. It joins with a deep petrosal nerve, so this is parasympathetic fiber. It joins the deep petrosal nerve, which carries sympathetic fibers from around the carotid. The two join together to form the nerve that I've talked before, which you all know, the Vidian or the pterygoid nerve, which then continues through the pterygoid canal into the pterygopalatine fossa and joins the pterygopalatine ganglion. So again, the greater superficial petrosal nerve joins the deep petrosal to form the pterygoid, and that's why this greater petrosal, superficial petrosal nerve is so important, as it forms eventually the pterygoid. So what we have here, this is the greater superficial petrosal nerve, which then went back to supply the geniculate, and from there into the internal auditory canal. And that explains why this patient had several nerve symptom from this meningioma. It's a little complicated here, but there are two ways how this endoneural spread can occur. So one, through the greater superficial petrosal nerves I mentioned. And if we look at this anatomic dissection, beautiful from Bassett's atlas, again, you remember, here's the trigeminal ganglion with the mandibular division, maxillary and ophthalmic. This is the greater superficial petrosal nerve that passes very close to the mandibular division, and right here is the middle meningeal artery also that comes up to foramen spinosum. So you can see that if you have tumor traveling along the nerve or tumor around this area in the skull base, it could involve the nerve and go back towards the geniculate, or the other way, from the geniculate travel anteriorly because of this relationship in this location. So also it could be tumor coming up through the, involving the middle meningeal artery, also involving. So this relationship around this skull base is very important. And remember, I talked before, perineural spread usually will be squamous, adenocystic, lymphoma, melanoma, rarely meningioma. Endoneural is more neurofibroma, schwannoma, and meningioma. So this is really, it has to do with which layer of the fibers covering the nerves is involved. But this is an example of what happens likely endoneural spread from this meningioma to travel along the greater superficial nerve towards the IAC. And here's another case to show this kind of perineural spread. This patient had a hard palate adenocystic carcinoma. And you remember, as I've said before, adenocystic, you have perineural spread automatically. You have to think of it. So I showed this before, this beautiful diagram from Netter. So here are the palatine fibers going back up to involve the pterygopalatine ganglion. But this is the pterygoid. Remember, the pterygoid, as it continues posteriorly, will join or form the greater superficial petrosal nerve. And if you see this patient, they had this lesion also traveled anteriorly to involve the skin over the cheek. Here the involvement of the pterygopalatine fossa, but notice there was involvement here traveling back to involve the seventh nerve. So again, the important travel route involving the pterygoid or the Vidian nerve and the greater superficial petrosal nerve. And again, via this pterygoid and the greater superficial petrosal nerve. Okay, what is the problem here? Correct, as Nate says, an enlarged genicular ganglion, possible lesion. Correct. As Anshu and Nate said, schwannoma. Of what? Which nerve is involved? What's the telltale sign here? Correct? The resident TZ said schwannoma, but not a vestibular schwannoma. Facial nerve, as Nate said. Look at the labyrinthine segment. It's markedly enlarged. And here's the MR showing the enhancement. And what we're dealing here, as this diagram shows nicely, this is a facial nerve schwannoma. Patient had a facial nerve schwannoma, had left facial weakness. And again, I want to point out, so here's the diagram of a similar lesion. So remember that here's the enlarged labyrinthine portion and involvement in the region of the genicular ganglion, and that's where we had the expansion here, a little bit of destruction of the wall. So again, this is involved and this is involved. This is specifically a facial nerve schwannoma, which is the most common lesion to involve the facial nerve tumor, that is. Another case we had, notice the enlargement of the labyrinthine segment of the facial nerve, of the facial canal. Look at the erosion and expansion of the roof in the region of the genicular ganglions. There's a mass here. Look at the mark enhancement here. A little bit of enhancement in this axial MR in the region of the labyrinthine segment. Here's the enhancement. And again, notice on the coronal a large tumor and an enlargement of the of the labyrinthine segment. Again, a facial nerve schwannoma. Now here we have a lesion in the fundus of IEC. Most likely, always you will say that this is a small vestibular schwannoma. But here we know that it's not a vestibular schwannoma because of the telltale sign of enhancement of the labyrinthine portion of the facial canal. So this was again this patient had left facial weakness, again a facial nerve schwannoma. This was a case that Ahmed brought to my attention. Again, CT finding noted the marked enlargement of the labyrinthine portion, destruction and enlargement in the region of the genicular ganglion. Here's the tympanic portion, markedly enlarged, and all the way back, this lesion involved the entire facial nerve. And look at the destruction within the mastoid. Look at the expansion here on the sagittal CT of the stylomastoid foramen, destruction of the mastoid segment of the canal, and erosion into the mastoid air cells. And again, on MR, we see very similar to this diagram that shows a facial schwannoma within the IAC in the cerebellopontine angle involving the labyrinthine portion. And here was the mass within the CP angle. Here's within the IAC and in the region of the geniculate. But in this diagram it stopped here. But here the entire, in our case, the entire nerve was involved, all the way back to the stylomastoid foramen. Now, here's a lesion. Another lesion we have to consider, which is much rarer than a schwannoma. Nate already mentioned that earlier. And that is a facial nerve hemangioma. Now, this is a case the Ajay and I spent quite a bit of time, and notice this patient also had facial nerve symptoms, but the lesion has kind of an irregular appearance, and that's kind of classic for a hemangioma. And again, notice the enhancement in the IAC and the labyrinthine segment. And if we look at this CT, notice again the mass in the region of the geniculate ganglion, and notice this little spiculation of the bone here. That's characteristic for a hemangioma that Nate mentioned earlier. And here's just from the literature to show you this classic appearance of a facial nerve hemangioma. Here's this kind of bony destruction with like multiple bony little spicules. Here's a lesion diagrammatically. So we were debating that this very likely, because of this appearance, was a hemangioma. The clinicians, however, felt that this was still a vestibular schwannoma, and patients been treated with gamma knife for schwannoma. But again, I would worry about a hemangioma when you have this kind of appearance. Now, here's another very interesting case. This was an older patient who actually fell down and came because of trauma. So he had a CT, showed blood in the subarachnoid spaces, and also on CT had this CP angle mass. So patient came for an MR where we see a large mass in the cerebellopontine angle, partially cystic, but also invading the IAC. Turns out that this patient had a history. It was done in another state, I think Massachusetts, many years ago, or several years ago. It wasn't clear at the time. Had a resection of a parietal tumor. So I had prior tumor resection and had actually a chronic facial droop. So what do we see? This diagram shows when you have a tumor within the parietal gland, you can get perineural spreading up through the mastoid segment of the facial nerve and can extend quite a bit up. In our case, it went all the way up. And if you look here, if you analyze the images, so here is abnormal enhancement of the mastoid segment in this patient. And as you follow, slice by slide, a little bit of enhancement at the genu. Further enhancement here. And then you get, and here's the enhancement of the geniculate ganglion, even a little bit of labyrinthine, and then it enters the IAC. So all this massive tumor in the cerebellopontine angle IAC is perineural spread several years later from this lesion which was in the parietal. So this is on the coronal plane. Even that this slice is this diagram is in the coronal plane, it goes along also with, here's the same patient in the sagittal plane. Again, look at the enlarged, thick, and enhancing mastoid segment. Here's again at the bend, moving up towards the geniculate ganglion. And on the axial plane, notice this is low down. This is the mastoid segment. Here it is, moving up. It's kind of thin here at the genu. Here it is. And notice, what do we see? We see the geniculate ganglion, and we see the IAC. So this massive, solid, cystic lesion is all perineural spread, which was originally a tumor several years ago. And that's what's characteristic for perineural spread, that there may be several year difference, separation between the original tumor and eventual perineural spread. And here's some other examples from the literature. Here's a parotid adenocystic involving here this region, and notice the enhancement of the mastoid segment. This diagram came from outlining this case. Here's another case of a parotid spindle showing the tumor kind of intermittent enhancement here, both in these two images here. Again, involvement of the mastoid, perineural spread. Sometimes you may even see on CT, this is normal for comparison. Look how markedly enlarged the mastoid segment of the facial nerve is. And here this patient had enlargement of the labyrinthine portion. Again, undifferentiated carcinoma of the parotid. And the last case I want to show today, again, this patient had a prior resection of a parotid neoplasm, presented later with symptoms, and notice a little bit of the tympanic portion, tumor involving the geniculate and the IAC. There was nothing else. So again, perineural spread of a parotid tumor ending up in the IAC, and as I showed in our case, a large lesion in the cerebellopontine angle. And this is the last case for today. Thank you for your attention.